I was wondering if you could say a little bit about when the scene, when the setting doesn't work so well, when a nurse comes in, and then how a primary care physician or a specialist or other care providers are engaged in the birdsong delivery of care. So moving beyond the really great 30-minute setting, what happens when it gets more complex, when there's care issues or family issues, and how does that interface with other care providers?
I think that, I haven't witnessed this, but I would imagine that given that this model is rooted in the community, it's grassroots or from the patient up. And part of that is collaborating very closely with the patient's primary care doctors. And so it's a phone call away if something needs to happen, that something goes wrong. And in New Amsterdam, one of the places we visited, the physician there commented that the Buurtzorg nurses, when they call, they know that they need to be called. And they also know that Buurtzorg nurses call before it's too late. And so it's that connectedness and that collaboration that is also critical. So I kind of see it as it starts with the nurse-patient, and then that connectedness, and it goes into the nursing team and the community, and continues on from there, if that answers a little bit of the question.
I also got the impression when we met with the doctors that there was a greater respect for Buurtzorg nurses versus the other nurses, and I think that's what's critical. It seemed to me as though they respected those nurses as equals, that they knew that they were high-quality professionals, and responded to them as such.
Yeah, and that's been based on trust. It's been based on experience and having a trusting relationship through experience.
And working in an interdisciplinary team as well. It really, also the physicians too, it's helpful that they are based in the community, whereas here, I mean, you could go to any provider in any end of the burbs, but it's community-based. And the providers, the one doctor that we did see, he wanted a Buurtzorg team managed in his town because he had heard of it and was frustrated with the previous system that's similar to our current home care system. Whereas if he had a concern, he would call and talk to a receptionist or a person that didn't know the patients. This way he was able to, provide care as well in collaboration with the nurse. So it just kind of built that trusting relationship as well.
I spoke with a physician too who trusted the Buurtzorg nurses a lot more. She knew that she could, the concern, if she was called, like you said, the concern was real and she needed to deal with it. She said she fought to get the Buurtzorg nurses on board, and she just had all these high comments about them. It was amazing.
I'm curious how the medical record and patient story are shared outside of the individual's home and with other persons involved in that individual's care.
Did you say medical records? Yes. Okay. I believe just the team has access to the medical records, so only nurses who are providing care within that team have access to their medical records on the intranet, the Buurtzorg. And then the chart that the nurses write on are in the home, which is what we do when I'm providing home care. The charts are in the home.
And also in that chart and the home, I remember as well asking that there was an H&P and other important information in that as well, because the physicians in the town do home visits. So they're able to go to the home and also have information that they need in the home because of the Buurtzorg nurses provided that.
And the second part of that question was about the patient story, things that are informing how to approach care according to that person's lived experience and their values. How is that shared and that person respected in that regard?
Well, it's so interesting because the teams plan the care. And so they meet a new patient, and then they sit together and they talk about the patient, and they use their shared expertise and what would be the best approach for various situations. So everyone knows, a team of 10 to 12 people may have 50 to 60 patients, and everyone knows everyone. And so they are all conversant with how to care for all these patients. And a brief story, a woman with dementia was able to continue living at home even though she couldn't remember to take her medications, because the nurses planned this really elaborate psychological intervention where they placed her medications in the kitchen on the top of the cupboards where she could see them but not reach them. So she still had her medications in her house where she knew where they were. And every morning at about 8 or 9 o'clock, somebody, just a friendly nurse from a Buurtzorg team, just knocks on her door and says, "Would you like a cup of coffee?" And then the nurse goes in the kitchen, prepares the coffee, brings back the meds. The nurse and the patient have a cup of coffee together. They have a chat, and the medication compliance enables this person to continue to stay at home independently. Her family and the patient, this is their end goal. Once a week, one of the nurses from a team surprises her on a weekend, maybe comes a little earlier and says, "How about a shower?" And so at least once a week she gets a shower and a change of clothes before she gets dressed. And so this enables her to continue this in living. Well, all of these steps were planned by the team, articulated in the chart, and everyone shares this knowledge. So it's a very intricate and elegant system for planning and delivering high quality, amazing care.
To kind of piggyback on that, if you have 50, 60 patients and all these nurses, how do they effectively communicate with one another and keep track of this and have it not be a cumbersome system?
What do they call it? The discussion board? There, is that what it's called? There's a discussion board that most of the, I don't know about how many percentages of your teams, but many of the teams now have iPads, and so they have access to the intranet, which is an impressive IT. We haven't even touched on the IT that supports this model. But there's a discussion board where the nurses can put postings on what just happened, and it can be sorted by patient or by team, if that's helpful.
And then also every week they have a weekly team meeting where they all meet together, have coffee, and talk about any issues or patients, and they're able to come up with these very eloquent nursing decisions right then and there at that meeting, and then deliver them. So everyone's on the same page. So it's just care planning that's very effective.
And I might note, one of the teams that I met with goes out for drinks. So they get a lot accomplished.
Every office we visited had a large table with food on it.
Yeah.
Yep.
Tea everywhere.
Lots of coffee.
Builds that team feeling, I think.
Can you touch on the IT system? I mean, because I know when a lot of systems are implemented here, it can be like a disastrous event at the hospital. So how can you talk about the IT system?
Well, the little that I know is that it really was built from the ground up, intended for nursing. So it's customized. Jos and his good friend
I think, was it
started
Karen
it.
that
And-
made a
Oh, sorry.
wonderful comment that it doesn't guide nursing, it supports nursing versus having it guide your profession, it just supports it. It was in Dutch, and I was able to maneuver through it, so it was that simple. And I don't know Dutch. But so if that says anything, very, very effective with scheduling, billing is all right there. You can look at the productivity, all the patient's charts with these discussion boards, putting in hours, everything is right there. And it's internet-based, so everyone has their iPads that they carry around. They can do charting at home. They can do whatever. But if someone gets called on, they have all that information right then and there. They don't even need to go to the office.
And just a quick note before our next question, if the people in Rochester and St. Cloud could, again, email your questions to Fabiana.
Thank you. I believe Jos touched on this earlier, but I just wanted to see what your experiences were. To what extent can you comment on the integration of intergenerational and integrative health and healing therapies? How are these services documented and paid for? I think we have a tremendous opportunity in this country to tap into the wonderful power and energy of intergenerational healing.
I'm not sure we can answer that question.
I'll take a stab. The intergenerational pictures that I see, I mean, it's the generations are in the community. This is a community-situated model, neighborhood care. And so the networks begin with the patient and family, so there's generations, and then also extend to the Buurtzorg nurses, the team, where there's other generations represented. So one example that we're aware of from Buurtzorg, one of the teams was working in a neighborhood, and they realized that there were quite a few immigrants and refugees there with a lot of unplanned pregnancies. Now, that is not the role of the Buurtzorg nurse to do outreach to pregnant teenagers with unintended pregnancies from refugee organizations or whatever. But there was a need in the community. So the view is intergenerational. The view is connecting individuals, no matter what their generation. And the view is to bring resources where the resources are needed and have the networks available. And so I think your point is excellent that this isn't about the elderly. This is about the neighborhood. And this is about what resources need to come together to support the people in the neighborhood. And from this work that's happening with the youth, there's a whole new Buurtzorg Young youth care for at-risk youth that's starting in the Netherlands. And 10 teams, 4 teams, 5 teams. So.
I can say, too, that there's also intercultural things going on. The nurse I followed went to a meeting of some Muslim women there, and just to be connected with that group. So she had a connection there, that networking that she was talking about.
The folks in St. Cloud have a question. They're wondering what was the experience like when nurses had to bring in other healthcare providers, such as physical therapists.
A lot of the teams have what's called Buurtzorg Plus, and that is bringing in physical therapists, occupational therapists, and speech therapists as part of the team. And actually that is critical, the physical therapy in particular, with problem solving in the home so that people can live there longer with safe transfers, all those kinds of things that are the PT specialty is very important. And they come and meet every 6 weeks. The PT, OT, and speech therapy come in and they collaborate in the weekly team meeting, but they join them every 6 weeks. Yeah. So that is a very important piece.
I also saw them reaching out with the Buurtzorg nurses' expertise. Like one of the nurses I worked with was a wound care nurse, and he was called on by another home to come and assess a wound. It wasn't necessarily his patient, but they're also called on for their expertise in other areas too.
I really appreciate your observations. As a Dutchman myself, I think a strong part of the Dutch culture is we're a very argumentative people, I would say. And it sounds like everyone is working very nicely together. There's actually a word in Dutch, a little bit of an old word, redetwisten, which basically means to wrestle with words, which is a very deep part, maybe some of the Jewish influence in the Dutch culture. For instance, a bottle of wine, 0.7 liters, is 2 glasses of wine per person, 4 glasses total, and that is intended to be the length of one conversation. That's why they didn't make it a liter, because that would be too much. And thing is, now, to go back to the U.S., first of all, anytime I have a bottle of wine with people, I end up taking half a bottle of wine home because we're done with the conversation because we need to get to the point. And we need to be done. And the second, there's a lot of pain, and I don't know, Jos might have experience, there's a lot of pain involved in these discussions. It sounds great, having coffee and everything. My sister is a Buurtzorg nurse, so I hear it from her, and she has quit many times nearly. I mean, that's like the ultimate, thing, is because of that discussion and that process. And then people work through it. The thing is, how do you think in the U.S. we can integrate? Because it is a very deep part of Dutch culture. If you go on any train in the Netherlands, and I highly recommend it, 80% of the people you hear around you are complaining and arguing with each other. You rarely hear people talk about how beautiful the tulips are or how beautiful. People are always, in a way, but it's a productive arguing, I would say, in many cases. And how do you think we can bring some of that wrestling with words, arguing with each other without being hurtful, yet still coming to a solution to the U.S. or to Minnesota?
I think maybe some of the teams were on their best behavior when we were there, but
we are Minnesota nice.
We are Minnesota nice, but they did talk about that and share that with us, that it's not easy, and they do have a lot of dialogue that goes on, and we've been encouraged from Jos and the other nurses also to, as this first team gets started, be honest right from the beginning, work through your stuff immediately, right away, don't wait, don't let things fester, and so I think I'm learning from them how to do this, and
there's this fundamental need for us to learn from this Dutch openness and communication style. We don't have it, and one of our responses, conditioned responses, is if there's a problem, we go to the next level, and immediately we look to a protocol, or we look to a regulation, or we look to a supervisor. This eliminates that opportunity. You have to talk to each other. How do you know what the patient needs? You talk to the patient. How do you know what the nurses need? You talk to the nurses. Fascinating idea for us. I mean, we Carina, how often do you talk to the other nurses that you work with in your home care agency?
I work on different days, so I don't even talk. Leave notes.
It took 6 months before I met one of the other home care nurses that I work with, and it was because we needed a care meeting, and it was because there were some issues, and that was the first time I'd met her.
And you have how many nurses working with this patient?
Well, this one patient, there's 4.
And you didn't know any of the others?
No, and there's now newer nurses that I've never met too. We just don't see each other. There's no change of shift because it's an 8-hour shift, and we just never see each other.
I was curious how social needs are met, being the social worker in the group here.
I didn't get the question.
What was that again?
How are social needs met in this model? So someone's requiring other services behind medical treatment or care. Who does that?
Housekeeping or lawn care or grocery shopping? That's a great question.
Well, I think that they try to draw from the existing supports, maybe at the intake, you find out what those supports are and where the gaps are, and then how you can pull in family or volunteer or community support first and work from that.
Mm-hmm. There's also Buurtzorg, which is a personal services sort of arm of Buurtzorg with lesser skilled people.
And I think that was kind of what we were thinking as well, is it sounds like you have the nurses doing, the showers and cooking meals, getting them dressed. So beyond that, I get, who pays for when they need housekeeping. We look at the whole picture, and to stay in someone's house, yep, they need the medical needs met, they need a shower, but they also need someone to clean, someone to, sit with them, that sort of thing. And, we can pay for, right now through PCA, having someone come in and do that. Just wondering how that is done.
Maybe I'm not sure. You could answer that.
Well,
yes, we have, I think, the healthcare part. So that's what Buurtzorg is doing. But they also, when, for example, doing shoppings is a regular problem, then they also try to find the solution for that. So that's the moment they try to involve volunteers or other people. So, and for the domestic care, and that we have buurtdiensten that's paid for by the county. So, and buurtdiensten and Buurtzorg are working together on a patient level. So when they think that it's necessary to coordinate, or because it can be very useful to use the information of this caregiver who's doing this domestic care, because he's there for 2 or 3 hours. So she has a good, so they use their different information. And it's in places we have now 80 or 90 teams with buurtdiensten. They work on the same principles, so they're lower educated, but also 10 to 12 caregivers. They're doing their planning also themselves, and they get support from a coordinator. So, it's not only higher educated nurses who can work this way, but I think everyone can work this way. And if I have the microphone, about this arguing, I know this team of his sister. No, they had some trouble with personnel. And I didn't say it was easy. I think it's not easy, but I think we are skilled to handle this arguing. And what we try to do, because I agree on that's a risk to spend a lot of time in things which are not useful. So what we did from the start was to support the teams with a solution-driven method. So we said you can have meetings for hours, bottles of wine. But I think you should focus on the solution. So what we do, and I'm going to show tomorrow some examples how teams does it and how they are supported. So if you, for example, if there is some kind of conflict in a team, then also try to find a solution, not try to find who's guilty, because a lot of people try to find the one who's guilty, and then a lot of time is spoiled on unnecessary things. So solution-driven, and teams have to learn it. So what you see is that you can't address it to another level. So you have to solve it yourself. And after solving a few of these problems, you see that the level of solving things is growing. So I think that the team where you've been, I think they were not, we didn't select them because they were so special. But I think they were are working for 5 years, these teams, and they experienced all these difficult periods, all these struggles. And it is also a fact that sometimes nurses can't work in these teams. So then I think it's better to pull the conclusion that it's better to find another working place than stay.
I think if I could add to that, it's all about relationships. And so in anything you do, and so often when you have a team, whether it's a team, for example, I have a team within AARP that is handpicked, or that you're brought into oftentimes personalities of the individuals or how people will get along with each other aren't necessarily taken into account. Often hiring managers are looking at the skills first, and what's your education, what are your skills, what can you do to move this organization forward, and they're not also thinking about how will this person work well with the other teammates that are here, for example. What I saw in Buurtzorg is these are self-made teams. These are people who are naturally coming together. Most of them have already had relationships with each other, and so it's working already because it's not like there's one manager over here that's hand-picking all of these people. What it is, it's this group self-making, and they have those relationships, and so they're able to be successful because they already know each other and they can work together and they respect each other. And that's not to say that there aren't issues, personality issues, but when you're working together so closely, you almost become more than a team. You become sort of like a family. And one of the teams that I was talking to, like I said, they go out for drinks. That's how they bond. And the teams find ways to bond with each other, and that's just as important because they can provide that quality care because they feel like a unit. So I think that's the difference in the Buurtzorg model.
I think we'll need to move on, but is there another question, Fabiana, from? Yes, Rochester, and then maybe we'll take one more question.
All right, Rochester is asking, how does Buurtzorg improve patient involvement in healthcare directives?
Healthcare directives, meaning like end of life?
That's the question I got. Do you want me to clarify that with them?
Well, I think what you're saying is, or what the person who's asking the question is asking is, how do the nurses work with the patients to develop those advanced directives? Is that right?
It sounds like it, yes.
Sort of, how do they plan together? How do they seek the patient input? I don't know how what you would say, but I would say just from the one observation that I had, okay, so it was one, but still, it was really good. It was, they have that relationship. They're having that daily conversation, and it's something that is a natural part of what they do, is because what they're focused on is the patient's wants and needs. And that's different than, okay, here it says in the chart, this is the medical item or care that needs to be delivered, and then off they go. It's, okay, here's the medical care that needs to be delivered. And, oh, by the way, what do you want? How are you doing? What do you need? What's not being delivered? How do you want this done? And, how do you see the future, evolving? So I would think if advanced directive planning is part of the culture there, they're naturally able to have those conversations, again, going back to the fact that they have the relationship. And that's key. And here we are so compartmentalized because we pay per service, that we're almost prevented from having those conversations. The death panels that were discussed during the debate around healthcare reform, that was all about paying the provider to have the conversation about developing an advanced directive. And the Buurtzorg nurses can have that conversation and not, worry about politics or being paid separately to have the conversation.
I have a really good example of that too. We went to visit an elderly couple, and after the nurse was done with doing, I asked the couple, I said, "Are you happy with the care you're getting?" And they're like, "Yes, yes, we are, but we know that we're going to have to move on to something else soon." So they already knew that planning. It felt like that planning had already been talked about. That they'd already been discussing that. And that was just okay.
And that's important.
Great.
So.
One more question. Is there somebody that's burning with a question in the back? Is that Teddy Potter? I see Teddy Potter back there.
Thank you so much. A lot of what you're describing I've seen implemented in hospice and home care over the years. So the philosophy is not new in some respects. I think the infrastructure is new, and some of the IT is new, and some of the smaller communities working together is new, but the philosophy of nurse-driven models is not new. So I'm wondering if this philosophy has been brought into the hospitals over in the Netherlands.
There's been conversations, Jos.
You want to speak from here, Jos? You could. Yeah. This microphone a little easier here. Come here. Capture you.
I'm just not used to these directions, but no, it's we have now a discussion with a lot of organizations, also with hospitals. So I give a lot of lectures to hospitals. So what you see now is that also the boards of the hospitals are thinking, shouldn't we change our way of organizing? But it's also happening in schools, and I also advise the police. So what you see is that in every place where the relationship between the professional and the environment is most important, then you should think about the consequences of how to organize it. So the context-driven way of organizing has become a very important discussion in Holland, in every field. So I even advise banks now, and I think that's very necessary.
Thank you. Round of applause for our